Hey,
Hey, how's it going?
good. Are you good to go as far as sharing and everything since it's Zoom and not Google Meet?
Yeah, I think so. Let me just pull it up and you can tell me if you see it.
Oh my God, your hair is so long.
I know the pixie's gone. It's like
It's
a ball.
wild.
Yeah, it's weird to see that I can like wear a ponytail now, right?
That and you just look like, I don't know, it's a much less edgy vibe.
Wow, you're calling me boring now?
No, you just look like, I don't know, like a professional adult as opposed to, I don't
Well,
know,
you're saying I look like a child all during my
a
residency?
resident, as opposed to a resident.
Great. Uh, That's funny. Well, speaking of change, I keep seeing your daughter on Facebook pictures and she's looking so much older now. She's growing up so fast.
Yeah, dude, she's ridiculous. She's thinks she's like 25, honestly. She really does.
You got your work cut out for you.
Yes, definitely. Definitely.
Is she in high school yet or is she still in middle school?
No, she's 12.
Oh, okay. Wow. See, like I would have been like, oh, she's 15, right? Or
No, she's 12.
wow, okay. Time flies. I was
It really
talking,
does.
yeah. I don't really like know any residents at NC State anymore, but I was talking to Price and I was like, oh, a little baby all grown up out to the big world.
Is he done? He's done, right? As of right now?
I
Like,
think in like 2 or 3 weeks.
yeah, yeah.
Don't they end like 4th of July or something? That's what I remember ending.
Yeah, summertime is like their ending.
Yeah. Yeah. Then they're gone. Out forever.
Gone forever. Where is he going? Do you know?
Um, he's like going to the middle of nowhere, like Indiana
Hmm.
or not Ohio, not Kansas. I'm pretty sure it's Indiana. I was like, why, why there? But Indianapolis, I think maybe.
Hmm.
Yeah. Okay, let me make sure you can see my screen. You can see that, right?
Yes.
Okay, great.
Yeah, much easier with Zoom than it has been with
Great. Well, thank you everyone for taking time today to show up to our journal club. I chose a scoping review that focuses on feline blood fibroblast growth factor, hereafter referred to as FGF23. And it specifically is looking at the literature that exists on these levels within cats that have CKD and also within healthy cats. And it kind of weirdly, I guess, syncs up nicely with our lectures at the core curriculum as well. So hopefully you won't get inundated with FGF23 information. But so as far as the introduction goes, we'll get a little bit into the history of FGF23 in a few minutes, but prior to the late 90s and 2000s, as many of you probably already know, we did not know that FGF23 was a main factor in regulation of phosphorus. So we had to indirectly look at it through calcium homeostasis. And we knew that PTH and calcitriol, as well as to a much lesser degree, calcitonin, all played a factor in how phosphate was indirectly regulated. We knew that calcitriol, which is the active form of vitamin D, acts in the GI tract when calcium is low to increase calcium and phosphate absorption. It also is produced in the proximal tubules to do the same thing there. Versus PTH increases calcium reabsorption from the kidneys and increases phosphate excretion. And then lastly, in the bone, PTH also increases calcium reabsorption, whereas calcitonin plays a probably very small biological role and decreases calcium resorption from the bone. And specifically in CKD, again, we're all pretty familiar with mineral bone disorder, but we know that during decreased GFR and decreased nephron mass, PTH is upregulated to inhibit the proximal tubular resorption of phosphate. And this allows the remaining functioning nephrons to excrete more phosphate per unit and allows phosphate to remain normal within the serum. And this works well in the short term, but in the long term, as CKD progresses, there is a point of no return and phosphate will exponentially increase as calcium decreases and PTH will rise. And this is referring to Bruker's trade-off hypothesis. I really liked this slide and this image from Dr. Brown's lecture, but it's again just a nice graphical representation of that phenomenon. Whereas GFR decreases here, we will have spikes in our calcium, or sorry, phosphorus, and decreases in our calcium. The intact nephrons will adapt, and we will get these stair-step increases in PTH and FGF23 to compensate. But again, once the GFR reaches a certain decline, there is an amplification, magnification phenomenon, a point of no return where the phosphorus will increase, as will the FGF23 and the PTH. And so then the clinical entity is CKD mineral bone disorder, which is a consequence of secondary hyperparathyroidism. This scoping review has defined it as one or a combination of the following, which is defined in humans as abnormalities of calcium, phosphorus, PTH, FGF23, and vitamin D. There are often accompaniments of bone turnover abnormalities, which can also be abnormalities of mineralization, bone volume, or bone strength. In our patients, we can see osteopenia or osteodystrophy, as this poor golden retriever demonstrates the classic rubber jaw, and then vascular or soft tissue calcification. And so the field was revolutionized in the late 90s, early 2000s when we discovered FGF23. They found that in humans, by studying phosphate wasting disorders, primarily they were looking at X-linked and autosomal dominant hypophosphatemic rickets. And in these patients, their hypophosphatemia was unrelated to vitamin D or PTH levels. And that's how they were able to discover the gene, which actually encodes for fibroblast growth factor 23. Similarly, around the late 90s as well, they found clotho, which is an essential cofactor for FGF23. And you can see here that clotho has to bind to the FGF23 as a co-receptor, which is then when it can bind to its actual receptor. And this FGF23 is produced by the bone. And as you can see here, the receptors are located in the kidney. Again, the proximal tubule is primarily where its action is. Once it binds to its receptor, it will activate MAPK signaling, and that then blocks the sodium phosphate transporter in the apical membrane, which then leads to decreased phosphate reabsorption in the proximal tubule. And so basically the other actions, once FGF23 has bound to its receptors, to also reduce renal conversion of calcitriol. We also know that other molecules normally synthesized by the kidney, such as again, 125 vitamin D and erythropoietin, also can induce FGF23 synthesis, as well as parathyroid hormone. And we will touch on this briefly as well on the review, but low magnesium has also been connected to these elevated levels. I just took this diagram. It is a little bit busy, but I think it's a really nice comprehensive brief review of what we just talked about from this Nature review study. And you can see here, this is the osteocyte, which is the site of FGF23 production, the bloodstream where the active hormone is released, and then the proximal tubule where it is binding to its membrane. So again, certain states such as anemia, hypoferemia, hypoxia will release EPO, which leads to FGF23 production and release. You also see that again with vitamin D, which can stimulate this pathway. And then you have the phosphate and calcium sensing receptors here, which will do a similar thing. So once that is transcribed in the osteocyte and release, again with clotho, it binds to its receptor in the proximal tubule to activate MAPK signaling. It inhibits vitamin D synthesis, as well as the phosphate reabsorption by the destruction of that sodium phosphate transporter. And then with CKD, you have this abnormal upregulation, presumably from phosphate retention and or these other abnormalities with EPO, etc. Okay, so how does that relate to mineral bone disorder? This diagram is taken from Dr. Foster's own review. And basically, it's thought that FGF23 may be the first indication to become elevated with phosphorus retention. Intact FGF23 is now commercially available to measure for veterinarians, either through IDEXX or Fujifilm vet systems. And so that the objectives of this study is really just to look at a scoping review of what studies exist in the literature right now, and basically do the studies provide adequate evidence to use FGF23 as a biomarker in clinical practice. I wouldn't say that there's necessarily anything earth-shattering or groundbreaking about this scoping review, but I do think that we have so few reviews and systematic reviews in veterinary medicine that, especially when it comes to nephrology, it is worth still going over these topics. And that's purely because based on our pyramid of information, you know, what's going to be the one of the best sources of studies for us, it's going to be systematic reviews at the very top, and then followed by other critically appraised topics. And this is also where scoping reviews would fit in. And if you're not familiar with what the difference is between a systematic review and a scoping review, as I was not, basically a scoping review summarizes findings from a body of knowledge, but specifically those studies tend to be heterogeneous in their methods or discipline. And so the reason the authors couldn't do a systematic review is that The methodologies of all of these different studies were quite different, including not only their assay, but the population of cats, how they defined CKD, etc. And rather than necessarily being able to say, does measuring FGF23, does this intervention improve specified outcomes? The scoping review can really only answer broader questions such as what's the nature of evidence for this test? What is known about this concept? So we're not necessarily going to be able to take away strict treatment points, such as like based on FGF23, I should be using this treatment, but rather the study says, do we have enough information to use FGF23 in clinical practice, and what do we know about it based on the studies performed? And basically they looked up articles published up to December 31st, 2022. They don't have a range of dates, so I guess in theory, articles could be published from 100 years ago, but most recently it's up to 2022. And they use their search for these articles on PubMed, CAB Abstracts, and Google Scholar with one author, and then another separate author screened the excluded articles. They only looked at observational or clinical studies that measured serum or plasma FGF23, specifically in the context of cats with naturally occurring kidney disease. And again, because of the variation in methodology and lack of clarity around overlap of data points, that's why a meta-analysis or systematic review could not be performed. So this is a graphical of their study design. These were their search terms, including FGF23, the full spelling of fibroblast growth factor, chronic kidney disease, CAT, phosphate, etc. And they removed a total of 180 duplicate records to get us down to 205 that were screened. Out of that, 112 were reviewed, and they were removed because they didn't include cats or not related to CKD or a clinical study. And then through a series of more exclusions, they basically got it down to 17 studies. It's always amazing to me how many we start out with and how few we end up with in our systematic reviews, but 17 is better than nothing, so. Of those 17 studies, they used 4 different assays, which were all sandwich ELISAs to measure the intact FGF23. And they had to be measured in plasma or serum. And all of these assays were validated in their own studies, except for the MyBiosource. I believe these authors reached out to the manufacturer who had some data, but nothing that has been published in the literature. And so the majority of 12 of them use this human FGF23, which is the Canos, which I believe is the feline version of what IDEX offers. And then the MyBiosource, MedFrontier, and this other biotech company. And most of them were looking at plasma, although 6 of them looked at serum. Most of the studies, not surprising, have come out of the UK, 11 out of 17, 2 from Japan, and then 1 each from Taiwan, Austria, Slovakia, and China. The vast majority were retrospective, but 3 were prospective, and about half of them only used geriatric cats that were 9 or older. Again, most of them looked at cats with kidney disease, 14 of them, and only 3 studied healthy cats. So there really is a much smaller population of data that we have for the healthy cats, unfortunately. And they defined healthy cats as non-azotemic, non-diabetic, and euthyroid. And we will get into the specifics of non-azotemic soon. So basically, a lot of these studies were done prior to 2015, at least for the healthy cats. So for example, 1 study reported healthy cats, however, 25% of them had an increased STMA. That's supposed to be greater than 14. Other populations looked at azotemic cats, Some were defined as renal azotemia when the creatinine was above 2, some were above 1.8, and another 2 studies said that azotemia was above 1.6. And 2 studies apparently didn't define what their azotemia was. But because of the timeline, only 1 study included SDMA measurement. So there may be a difference in how we would classify those patients now. Of the studies that looked at renal azotemia, 4 subdivided them by IRIS CKD stage, and 2 only looked at stage 1 as a separate category. So this is a graphical representation of the FGF23 measurements according to CKD stage. And this graph has put them each into their own categories based on what assay they used, since it was difficult for them to directly compare FGF23 measurements across.
Yeah, they emailed me as well. They were working through. Sorry.
No, I don't think she's talking to me. So yes, these are the 4 different assays that were used. The very light blue is healthy. You can see that for most of these assays, those cats tended to have the lowest FGF23 values, versus as we go up from stage 1, 2, 3, and 4, I realize it is hard to differentiate between this stage 1 versus stage 4, but it is the darker maroon color that is stage 1. And again, only 2 studies looked at stage 1, but as we progress through stage 3 and 4, we tend to see an increase in FGF23 levels. And you can see that across the assays for all the studies. But again, the actual value of the FGF23 could not be directly compared across these assays. And this is a similar graphical representation where they are just looking at a single assay in each box. And you can again see that trend followed, where as we progress through the stages of CKD, FGF23 tends to increase as well. But you will also note that there is a pretty large overlap between stages and even between some of the healthy cats, depending on the assays that were used. But in general, they would say that as CKD stage increased, FGF23 increased as well, with there being a wide variability. None of the published studies showed a clear differentiation between healthy cats and cats with CKD, just based on FGF23 concentration alone. So that's also important to know. So then the authors asked, what did the studies that exist in the literature have to say about FGF23 in regards to phosphate overload? And that's where things got a little bit interesting, because the data was conflicting. 4 studies did find that FGF23 concentrations positively correlated with the serum phosphorus concentrations, whereas 4 of the other studies that they looked at showed no correlation. This is just one of the studies that they look at, specifically a study by Dr. Geddes from 2013, where they are looking at CKD just stage 2 and 3. If you are stage A, then you have a phosphate concentration below the IRIS cutoff of 4.5, versus 2B would be above 4.5, and then 3, the cutoff was above and below 5. In this population, there was a significant difference, with the uncontrolled phosphate substage B groups having a significantly higher FGF23 compared to the cats in 2A and 3A, but not every study showed such a nice correlation. And then when it came to FGF23 and diet, many of the studies that examined diet showed that in healthy older cats, if you fed them a moderate protein, low phosphate diet versus a higher protein, moderate phosphate diet, there was no difference in FGF23 over an 18-month period. but keep in mind that that was for healthy cats. However, if you took the population of cats that had stage 2 through 4 CKD, the renal diets did cause a significant reduction in the phosphorus and the FGF23 compared to the cats with CKD that were not on a renal diet. And FGF23 decreased in both the hyper and the normophosphatemic CKD cat groups. Although if you just looked at phosphorus by itself, that only decreased in the cats that were hyperphosphatemic. And so this is in relation to diets. And both of these studies that discuss the diet, again, it was 2 out of the 17 studies, but they were clinical trials rather than retrospective, I believe. So then the author chose to look at, I think she had a total of 5 studies in the scoping review that tried to examine the relationship between FGF23 and calcium. And these patients were both healthy cats and mostly cats with CKD, but we do have data from both. So the first study that they looked at by Miyakawa from 2022 looked at cats with CKD that had normal calcium and high calcium, and it was both ionized and total calcium that was examined. And their study showed that cats that had ionized hypercalcemia, so this population here that had normal phosphate did have significantly elevated FGF23 compared to the group above them that had normal ionized calcium. And then similarly, they saw a trend as well for the total calcium, where the cats with CKD and high total calcium also had higher FGF23. This was compared to the Vandenbroek 2017 study. She looked at, or they looked at CKD cats and healthy cats. And actually in their population of cats, there was no difference in the cats that had high versus normal total calcium, and same with the healthy cats as well. In the later study that they came out with in 2022, again, when they just looked at cats with CKD, this time there was a significant difference where the cats with CKD and high total calcium now did have a significantly different and more elevated FGF23. So again, the studies can be a little bit conflicting. 2 out of the 3, at least here, showed that a high calcium could lead to or could be correlated with an elevated FGF23. The next 2 looked at not just strictly normocalcemia versus hypercalcemia, but they wanted to look at trends in cats over time, specifically in relation to which cats might become hypercalcemic once they were placed on a diet. So this first one from 2021 looked at FGF23 as a baseline in cats versus those that then went on to become hypercalcemic versus normocalcemic with time. I believe it was over 12 months. And what was interesting is that in those cats that had a calcium uptrend over time versus those that did not, there was no significant difference in their FGF23. And so the FGF23 at baseline was not an independent risk factor for increasing total calcium. And this was after transitioning these patients to a renal diet. And then the GETIS study from 2021 had a similar outcome as well, where they were following cats over 18 months. And this one was slightly different because they had an initial patient population that had high calcium at diagnosis versus ones that were normal and became hypercalcemic on the renal diet. But the outcomes were quite similar in that even though the diet change for some cats resolved hypercalcemia or caused the hypercalcemia, the FGF23 could not predict which cats would become hypercalcemic. nor did the FGF23 become significantly different for those patients over time as well. So those two were in pretty good alignment with similar findings in regards to diet specifically and hypercalcemia subsequently. And then lastly, we only have one study that examines the relationship of magnesium to FGF23 in cats. But specifically from this article in 2018, we saw that cats that had low magnesium tended to have higher FGF23 as well. But that has only been validated in this study to my knowledge. Okay, so then the authors asked, can FGF23 predict which cats may develop azotemia? And we have two studies that tried to answer that question to show it whether it could be predictive of the development of CKD. Specifically, this figure is from the Sargent paper in 2019. And depending again on your definition of stage 1 CKD, at least in this population, when animals had a creatinine less than 2, but an SDMA greater than 14, the FGF23 was significantly higher than that population that did not have an elevated SDMA, and that was despite no difference in their phosphorus. And then the Finch paper from 2013 also showed that healthy cats that were followed for a year had a higher FGF23 when they went on to develop CKD within that 12-month time span. So I don't think there's enough information to definitively say, but potentially it may be, again, an early biomarker that is elevated before overt azotemia. Again, we don't have a lot of papers in this cohort that used SDMA as a marker, so that outcome could be different if we were to actually design a study where SDMA was included for every patient. So as far as the discussion goes, there are a few big takeaway points, but there's still some disagreement based on studies. I think it's safe to say that most, but definitely not all, found a positive correlation between phosphorus and FGF23. So the higher the phosphorus, the higher the FGF23. And based on a single study, we wish we had more, but we do have one that says measuring FGF23 may help identify cats with early stage CKD that indicates phosphorus overload with normal serum phosphate levels. We do have some evidence again that feeding a renal diet to cats with CKD may decrease FGF23 levels. And we know that in regards to calcium, probably most accurate if we can measure it in a normal calcemic patient prior to starting a phosphorus restricted diet. But unfortunately, the FGF23 level may not help us predict which cats may become hypercalcemic after that diet change. And then last but not least, we have some evidence indicating that FGF23 may be a predictor of CKD progression. And we know that that is certainly the case in human medicine as well. And I believe we have a few studies looking at that in dogs as well, showing similar findings. So I just wanted to briefly show the IDEX flowchart. Again, I'm sure you guys are familiar with that. If you are using the IDEX biomarker, they indicate that it should not be measured in cats with normal kidney function. And as of right now, they are recommending its use for cats in CKD stage 1 and 2. Again, they recommend measuring it only if the phosphorus is below the 4.6 cutoff recommended by the IRIS group. And then they have it split into normal, which is less than about 300, borderline, which is 3 to 400, and increase, which is greater than 400. If it's normal or borderline, they basically suggest rechecking again in 3 to 6 months. If it is above 400, then they very generously offer the help of targeted therapy is indicated for phosphate reduction. Again, we have studies that show that diet may help with that. And then we, as a group, certainly have discussed using phosphate binders, but as of right now, there are no published studies that look at the effects of phosphate binders on FGF23 levels. So those are the major takeaway points from the paper, and I was hoping to go over some discussion questions with the group. I am curious to see of people on the meeting, how many of us are frequently using this to stage our CKD cats. Is it something where, you know, in a university, has your university started measuring that for you, or are people purposely still sending it out to IDEX to get it measured? Or if you use an IDEX lab, are you using it commonly in your feline CKD patients? Any feedback from the group out there? Who's using it? Who's not using it? We use an IDEX lab, so I can say that we have been using it fairly frequently. But I'm curious what people in academia are using. So Dr. Byron said she has asked Dr. Quimby if they're going to do it here, presumably at Ohio State, but it is very costly to get the plates. Is anybody else having that issue in academia, or are you guys sending it out to IDEX just for that measurement alone, or are you not using it? Okay, Dr. Vaden says we send to IDEX, yes. So does Dr. Lobato as a solo test. Okay, so it seems that a lot of us are sending it out to IDEX, which makes the most sense. And I'm just curious if that's something that's become part of your routine CKD staging, or I guess I'm curious to know how often people are measuring it to decide whether or not to use a phosphorus restricted diet in cats with stage 1. Are you always measuring that level before you start a renal diet, or is that not really affecting your decision, and maybe you're starting a renal diet first and then you're checking FGF23? Dr. Vaden says routine in cats that are not yet hyperphosphatemic. I would agree that that's how I'm using it as well. But I am just curious if from a nutrition standpoint, how people are using it. Okay, Dr. Vaden said we use it to guide binders more than diets. Most cats are eating renal diets when we submit it. I think that's probably 90% of how I'm clinically using it as well. I do feel that, at least in Southern California, I'm not sure about your guys's client population, we get a fair number of owners with cats with early stage renal disease. I would say more typically early stage 2 rather than true stage 1, but they've of course read the hype on the internet about how renal diets are bad for their cats. And so sometimes I will try to use it as evidence that a cat might need a renal diet more, but I'm curious if other people are using it for that reason or not. Okay, so it looks like Dr. Marino says she works with a cat hospital. If they're concerned for CKD in cats, not azotemic, but elevated SDMA, maybe changes on imaging, they use it to determine whether or not to start a renal diet. So it seems that some of us are using it specifically for that decision making. whereas maybe others of us are using it after we've started a diet. And I'm also curious, I don't know if anybody, so at least for dogs, we are still relying primarily on PTH, but I'm curious if people are, in the absence of hypercalcemia, is there anybody in the group that is still measuring PTH with FGF a lot in cats, or have people primarily just moved to measuring FGF23? And, or I guess, is anybody measuring calcitriol? Yes, Dr. Vaden pointed out there is an FGF23 assay in dogs. But yeah, I haven't used it because I don't know what the reference range is. She does
So
not.
the IDEX assay actually works in dogs. That's a well-known hidden fact.
I do remember Dr. Calgill has shared that with me too. And he said I could try to reach out to the UK group to see if they could give me reference intervals for canine FGF23, but
They only look at cats. They
yeah.
mostly look at cats. Yeah, I mean that's the hard part, is it could be way different or it could be about the same. But anyway, we don't measure PTH routinely anymore since we don't use calcitriol very much anymore.
Yeah. Okay. Yeah, I agree. I don't measure PTH in cats. I can't really think of the last time I did, but I am curious as a side note. I know this does not directly relate to cats and FGF23, but I'm also just curious in relation to dogs if people are still relying on PTH. I think that Michigan is now offering measurement of calcitriol levels as well. And I guess I've always understood from a pathophysiology point of view that low calcitriol may be also contributing to secondary renal hyperparathyroidism, but I've yet to find a CKD patient that has renal secondary hyperparathyroidism and true low calcitriol. And I'm just curious if people are measuring calcitriol in their canine patients and or if they are truly coming up with low calcitriol in their dogs. Because I have not seen it. I'm sure it exists, but I thought it was going to be a common phenomenon and it's not, that I can tell. But maybe the assay is not, I don't know, meant for that either. Okay, well, the only other questions I had for the group is, again, in regards to FGF23, if you're using it, are you only using it for stage 1 and 2 cats, or are people looking at information for general trends in their later stage cats? I know the 300 cutoff is not accurate necessarily for later stage 3 and 4, but I'm curious if people still look at it as a trend over time to decide on phosphorus binders or other medication. And are you truly waiting 3 to 6 months after you've instituted therapy to recheck the FGF23?
I've not been here for quite a lot of this session. Apologies for that. I've joined quite late, but I can put my video on as well. I'm happy to speak to some of these points. I mean, we've measured FGF23 a lot, although because we've been doing it in our research clinic, we've quite often been doing it retrospectively. We haven't necessarily been using it prospectively to then make decisions on what we're doing with phosphate restriction in these cats, but kind of based on all of that kind of, previous measurement and getting a feeling for it, I think you definitely could use it to look at trends for these later stage cats. I guess for a lot of these cats, the phosphate has elevated at that point. And so I don't know if you're going to get an awful lot more information from measuring FGF23 than you would do looking at your phosphate concentrations. But if, you know, it isn't always high in some of these cats, some of them still seem to maintain beautiful phosphate concentrations. So then you might find the FGF23 useful, but I definitely, like you say, I wouldn't be trying to necessarily expect to keep it below 400 even, or, you know, we can see much higher FGF23 concentrations than 400 even in the stage 2 cats. But I think there's still some potential utility there. Just because a cat is now in stage 3 or stage 4 doesn't mean that suddenly it's not useful at all if the phosphate is still well controlled. And I don't think you need to wait 6 months to recheck it. But I think it could be, you know, waiting at least a couple of months. I wouldn't be necessarily trying to recheck it sooner than that to really see how it's trending.
Yeah, I think that makes sense. The 6-month time mark is always like, ooh, that seems like you're waiting a very long time. So yeah.
Yeah, you don't need to wait that long.
Yeah. Yeah, and I know that others have been faced with that conundrum, and I think we were recently discussing it on the listserv. You know, what do we do with that subset of cats that have the elevated FGF23? They're normophosphatemic. We start the renal diet, they become hypercalcemic. The FGF23 is still elevated. It's just a hard dilemma for me because I hate to medicate a problem I created with diet, but you know, it's hard to also just ignore the problem that you know is still there. So I guess I'm just curious if people are, you know, primarily fixing their problems in that regard with diet alone, or if people are commonly reaching for cinecalcet or alendronate for those cats. Because I have yet to use cinecalcet in a cat, but maybe I'm just being too chicken.
So I'm also happy to speak to that point if you like, but other people do feel like you can jump in. It's just, and I talk about this a bit in my lectures that have just been uploaded as well onto Canvas. But so if a cat becomes hypercalcemic, or if their hypercalcemia exacerbates on renal diet, this does tend to push their FGF23 up higher. So the typical response of FGF23 is that it will elevate further if a cat's hypercalcemia either develops or gets worse. So I think in that circumstance, you can't use the FGF23 to guide you on the need for phosphate restriction. I feel like it's almost the opposite, that actually you have to back off on the phosphate restriction for those cats. So I always tend to modify my dietary approach if we see hypercalcemia developing after we've started renal diet. Then I'll switch to something that is less phosphate restricted, and we'll try to meet the criteria that was in the recent paper from Valerie Parker's group. So look for having a total calcium concentration of the diet less than 200 milligrams per 100 kilocalories. Look for a calcium to phosphate ratio that's less than 1.4. And if the cat was normocalcemic before it went on renal diet, then they pretty much always resolve when you then change the diet, and you'll find that the FGF23 drops back down as well when you resolve the hypercalcemia.
So I have, we definitely talked about that, I think, on this last listserv case, and I have definitely seen that, but I guess I'm just curious what you do with that population where you measured the FGF23 when the cat was normocalcemic before it ever saw a renal diet and it was elevated. So that's what made you start the diet. So then in that case, wouldn't you argue that the phosphate overload was preceding the hypercalcemia? And what do you do with that juxtaposition?
Yeah, so then in that case, so once as long as you're not making it worse with the diet, so balance out your diet
Right.
to try to resolve the hypercalcemia, and then use a non-calcium containing phosphate binder for your phosphate restriction, would typically be how we tend to approach it. So we tend to use aluminium hydroxide and add that in as well.
And that phosphate binder doesn't exacerbate the hypercalcemia all over again.
No.
Okay.
No, it doesn't seem to, as long as it doesn't contain calcium.
Yeah.
Then that doesn't seem to make it worse. It's not just the fact that you're giving less phosphate, it's also the calcium to phosphate ratio and how much calcium is available for absorption from the GI tract that I think is contributing to the hypocalcemia for these cats.
Okay. I think that's a very great point, because I don't think I put that connection in my brain before. So I was always so focused on the phosphate restriction. But yes, excellent point. The calcium to phosphate ratio, I guess, matters more. So thank you for pointing that out.
No problem.
Okay. Well, that's great. I mean, I think that is a lot of my discussion. I'm excited to see that I think a lot of people use it the same way I do. I think it's just figuring out the calcium and phosphate together that's been sometimes challenging for me as a clinician. And I don't feel like I see it very commonly in cats, but I do feel like I have that subset of dogs that have a total hypercalcemia, but a normal ionized, and their phosphate is still sky high. And then I'm back to not understanding what to do again with the calcium phosphate product. Because I feel like we focus so much on ionized hypercalcemia that when we get to the calcium phosphate product, it's a separate story almost. And that sometimes is also confusing to me as a clinician. But I guess in that instance, I'm more likely to use cinacalcet, but I'm not sure about everybody else, or if they see that very much. I know that's a dog problem, maybe. I can't say I see it too much in cats, but yeah.
Hello, can I just also add a little bit?
Mhm.
Hi, I'm just going to turn my video on as well. Hello.
Hi.
I'm not sure if I'm kind of qualified to speak here, but but I think just going back to the hypercalcemia and the phosphate restriction, we've kind of recently done a study. It's yet to be published. It's going to be published, but we talked a little bit about that at ACVIM recently. And again, I'm not sure how helpful this is because it's not commercially available at the moment. But we've done a prospective diet trial looking at two different diets. One is essentially very similar to the original renal diet for Royal Canin, and then the other one very similar, but with sort of roughly 3.5 to 4 times higher dietary magnesium level, but while still maintaining the same calcium and calcium to phosphorus ratio and the dietary phosphate level in the magnesium enriched diet. And what we found is that we didn't see any cats that developed hypercalcemia in that short period of time during the study trial of 4 months. And then we saw 4 cats that developed ionized hypercalcemia on the other arm of the study. So potentially this is something that may help to further stabilize the hypercalcemia or further stabilize the calcium level, or in other words, not inducing hypercalcemia while maintaining a kind of a substantial degree of phosphate restriction. But yeah, just something
Yeah, that's interesting.
to mention. But yeah, it should be out quite soon in terms of the paper. It's just with the publisher. But again, as I said, it may not necessarily help too much at the moment with the cases that we see at the moment because it's not commercially available. But it's interesting.
Yeah, I mean, I think it's something to bear in mind. I would be the first to say that I'm guilty of overlooking magnesium. Sadly, probably the most commonly out of all the electrolytes that I keep track of. And I think some of our chemistries don't even come with magnesium. So if you're not thinking about that and you don't specifically request it, how often do we miss it, you know? So I think it's a good reminder that we shouldn't leave magnesium out of it.
It's important.
Yes.
Thank you.
You know, thank you. Yeah. Okay, well, that is all that I have. If anybody else wants to chime in, now's your chance. But I really appreciate the discussion and the experts showing up today to help me out. It's definitely one of my least favorite parts of CKD, but it's fascinating. So
It's literally my favorite bit. So I'm very happy to discuss any cases of like CKD, NBD, hypocalcemia in cats, anything at any point. Just drop me
okay,
a line.
I'll take you up on that. Be careful. Okay, well, thank you everyone, and I hope you have a good rest of your day.
Thank you.